Can you hear me?
We can hear you.
Thank you. Before we begin, are there any questions? Looks like I should wait a bit. Somebody's just logging in. Let's go here. My computer is going to be slow because of I'm still making the lecture file. Oh, it just finished. Great. Few things to mention about the unknown project. I talked to you about that one, so I don't need to tell you guys. I think I mentioned that if you give me a test request in an email, I will not honor it. And that's because I want all of the information for the unknown project put in your unknown notes so that both you and I can find it when we want to look it up. And I think I mentioned, but let me repeat it just in case I forgot, that you are allowed to do one confirmation test if after you identify your unknown bacteria, so that you can do one more test to confirm you have the bacteria that you think you have. Any questions about any of that? I'll move that up. Let's go to the syllabus. So today is February 6th, and we're discussing Lab 6, disk diffusion and antibiotics. Any question about what we're doing? All right, let's move on to Lab 6. Load it up a little. Lab 6, disk diffusion, evaluation of disinfectants and antiseptics, and antibiotic effectiveness. There is some reading to do in this lab, so please read page 177 about terminology of microbial control. Please read page 187 to 194 about the principles of effective disinfection, evaluating a disinfectant, and page 196 to 197, particularly table 7.8, talking about chemical methods of microbial control. Then read page 554 to 555, looking at specifically table 20.3, talking about antibacterial drugs, commonly called antibiotics. And then lastly, read page 567 to 569, talking about tests to guide chemotherapy, the disk diffusion methods. And mainly we'll talk about the Kirby-Bayer method. It's sometimes discussed as the disk diffusion method. There's some supplemental materials in this lab. There's some video clips for you to watch, and there's a virtual lab for you to pull down on your computer and actually do the lab online. The learning objectives for this module: one, be able to identify the type of chemical agent and the active ingredient used in various disinfectants and or antiseptics. Two, evaluate the effectiveness of disinfectants and or antiseptics using the disk diffusion method. That's also called the Kirby-Bayer method. Three, determine the mode of action of various antibiotics. Four, evaluate the effectiveness of various antibiotics using the disk diffusion method. 5, list variables that influence the antibiotic diffusion method susceptibility testing. And then 6, be able to define the terms. What's sterilization? What is disinfection? What is a disinfectant? An antiseptic? What's a bactericidal agent? What is a bacteriostatic agent? So we're talking about like antibiotics. What's a bactericidal antibiotic? What's a bacteriostatic antibiotic? Obviously, what's an antibiotic? Uh, the spread plate, how you make a spread plate, and then what's the zone of inhibition? Any question about any of these terms or objectives? All right. Sterilization is the elimination of all viable organisms, including endospores. Disinfection is the destruction of vegetative cells, but not necessarily endospores. So when you clean a toilet, is that sterilization or disinfection? Anyone have a guess?
Disinfection.
Yeah, it's disinfection. When we use bleach on a toilet, you do not necessarily kill all the endospores. Bleach does not kill all endospores, and there's some species which are more resistant than others. I don't know what they are, but that's just that. Disinfection does not kill endospores. Disinfectants are chemical agents applied to inanimate objects. Antiseptics are chemical agents applied to living tissue. As I mentioned, bleach on the toilet is a disinfectant. But if your cat comes home wounded and you put bleach on the wound, that would be an antiseptic because you're putting it on living tissue. So even if it's the same chemical agent, it has a different term. Usually, antiseptics are less caustic, less toxic, whatever, less harmful than a disinfectant. Many antiseptics, if not all of them, are also not as strong as far as killing as a disinfectant. Any question about any of that? So strict antiseptic, meaning a an agent we don't usually use to clean an inanimate object, would be something like tincture of iodine, a very good antiseptic, but it's not as strong as bleach. And it's not harmful to human skin while we use it as an antiseptic. To evaluate the effectiveness of chemical agents, the surface of a nutrient agar plate is inoculated with a particular bacterium. You get the bacterium to grow everywhere on the plate so that we call it a lawn of bacteria. Sort of like a lawn of grass has grass everywhere. Paper discs saturated with different chemical agents are then applied to the surface of the agar. The chemical agent diffuses into the agar, establishing a concentration gradient around the disc. You then incubate the plate overnight at 35 degrees C, and then take the plate out and you'll have bacterial growth around the plate. If there are zones of inhibition around the disc, the paper disc containing the antibiotic, then it's safe to assume that the chemical was effective for that particular bacterium. Conversely, if there's no zone of inhibition, the chemical is assumed to be ineffective. Now that's different. Effective and ineffective is different than sensitive and resistant. Any question about any of that? I'll talk in a little bit about what we mean by sensitive and resistant, but they have a special definition. Here's a table of some common disinfectants and antiseptics, giving the category, the chemical agent, the general action, and the preferred use. Like alcohol, ethanol, isopropanol are a really, really weak antiseptic. And actually, we call them more a degerming agent because they really don't kill all of the cells when you put the alcohol on your skin and then swab the area before a needle injection. All it does is it reduces the number of bacteria in the region to a safe number to go ahead and give the injection. It does not kill all of the bacteria in that region. So, for example, you would never want to use alcohol to prep a patient for surgery because the patient would get a bacterial infection from the surgery working on the area that's been only alcohol swabbed. Any question about any of that? So we have better antiseptics, and those are the ones they use in the hospital. They used to use a lot tincture of iodine before surgery because it was very effective. And then the advantage was it also colored the region where you applied the tincture of iodine. And so they knew what area was, I don't know, not sterile, but uh, decontaminated, prepared for surgery. Aldehydes like formaldehyde, formalin, are very good disinfectants, and they're one of the few disinfectants that actually kills endospores. Most disinfectants do not kill endospores. There is an exception, and that's the peroxygen, like hydrogen peroxide, which we use as actually an antiseptic more than a disinfectant. This does kill endospores, and that's mostly used as an antiseptic, hydrogen peroxide. But you could use it as a disinfectant, for example, and it'd be a good one because it does kill endospores. Halogens, tincture of iodine, chlorine bleach are an example. Iodine used as an antiseptic, chlorine bleach as a disinfectant. Mercury, heavy metals, uh, were used for a while when they, I don't know, were first invented and realized that they had antibacterial properties. But then the medical establishment stopped using them because there were other agents that were better to use, more effective, and then less toxic. I forgot to mention that in the last lab, but the heavy metals are toxic to people. You don't want to consume them, for example. So they're usually applied on the skin. But you can use them as an antiseptic or a disinfectant. Their use has come back. The reason why their use has come back is because when we use these, they do not increase the risk of the bacteria becoming antibiotic resistant. And because of antibiotic resistance being a problem, we've now brought heavy metals back and used them. Like oftentimes in surgical dressing, they'll put a heavy metal in there to help prevent the wound from getting infected. Any question about any of that? All right, phenolics. Phenol was something that Joseph Lister treated his patients for before engaging in surgery, and it was the strongest antibacterial agent he could find, but it actually wasn't that good, especially for something treating for surgery. We now have antibacterial agents which are many, many times, like hundreds of times better than phenol. But when his days, it was the strongest antibacterial agent he could find, and it actually was kind of toxic to human skin, could cause cancer. Of course, he didn't know that. Was had a disagreeable odor, and then was corrosive both to the skin and to like the surgical metal instruments. So it's not used anymore in surgery, but anyways, that's an example. Today, it's mostly used as a disinfectant, but it can be used as an antiseptic in low concentrations. Surface active agents, you actually know them, soaps and detergents. are surface active agents. Quaternary ammonium compounds, a more recent surface active agent, which they use oftentimes in hospitals because they're a very strong disinfectant. Any question about any of them? All right, let's move on. The zone of inhibition depends only partially upon the sensitivity of the organism to the disinfectant or the antiseptic. So when you have a zone of inhibition, the size of it can depend on the sensitivity of the organism to it, but there are other factors that affect the zone size, including the concentration of the chemical. Generally speaking, the more concentrated the chemical, the larger the zone of inhibition will be. The molecular weight of the agent will also affect the zone size of inhibition, and that is the smaller the molecular weight of the agent, the larger the zone of inhibition will be. It's because the smaller molecule can diffuse through the agar more easily and further than a larger molecule. And then the density of the bacterial inoculum can affect the size of the zone of inhibition. A very dense bacteria put on the plate will reduce the size of the zone of inhibition. Any question about any of that? All right. Let's talk about evaluation of antibiotic effectiveness. Antibiotics can be categorized as bactericidal if they kill susceptible bacteria, or they can be classified as bacteriostatic if they only inhibit the growth of bacteria. If we're using a bacteriostatic antibiotic, we rely on the host immune system to assist in the elimination of infection. You apply the bacteriostatic antibiotic, and that prevents the bacteria from growing, but it does not kill the bacteria. And so if you were to stop applying the antibiotic, the bacteria will continue growing. And it's not an antibiotic you want to give to an AIDS patient because obviously a bacteriostatic antibiotic, we're relying on the host immune system to remove the infection from the patient. Any question about any of that? When you look at a zone of inhibition, you cannot tell if the zone of inhibition happened because the antibiotic is bactericidal or if it is bacteriostatic. The only family that I know off the top of my head, which is bactericidal, at least most of it, is when we look at the zone of inhibition to the members of the penicillin family, like penicillin G, most of that zone of inhibition will be bactericidal, where the antibiotics is killing the bacteria. It is true at the very edge of the zone of inhibition that the antibiotic might be bacteriostatic, but only the very edge. Most of the zone of inhibition will be bactericidal. And I don't know of any examples to an antibiotic that is bacteriostatic. I meant to look that up and I just tried and didn't get an answer and stopped looking and I never went back. Most antibiotics that I know are bactericidal, at least the majority of them, meaning most of the zone of inhibition. Kirby-Bauer disk diffusion test is the most common method used for antibiotic testing. The results of such testing can help a physician in choosing which antibiotics to use when treating a sick patient infected by bacteria. What you do is you isolate the bacteria from the patient, meaning you have to grow it up as a pure culture, and then apply it to a petri dish. Let me blow this up. Get the bacteria to grow essentially everywhere on the plate. Why it's essentially cloudy everywhere except on the zone of inhibition. Apply the paper disc to the plate. Incubate the plate to allow the bacteria to grow, and then look at the plate. What we do is You grow the plate for about 18 hours at 35 degrees C, and then you look at the zones of inhibition around the antibiotic. Let me blow that up a little further. And obviously, this one and that one, maybe a little bit of that one too, don't have much of a zone of inhibition, if any. And so you can assume, that does have one. Now that I look at it blown up, it's just that it has a growth of bacteria inside there. Um, so probably what happened is this is a bacteriostatic antibiotic, and it had the zone of inhibition here. And then with time, even only 18 hours, the antibiotic stopped working, and now the bacteria started growing everywhere in the zone of inhibition. Usually an antibiotic lasts longer than 18 hours, but that's what looks like happened there. This one looks like the bacteria is resistant to that antibiotic, and the same with that one. And then that one looks like the antibiotic is sensitive, the bacteria is sensitive to this antibiotic. However, we can't tell yet. We can only assume that the bacteria has been inhibited by this antibiotic. You can't specifically to state whether it's sensitive or resistant to it until you measure the size of the zone of inhibition and compare that to the NCCLS table, and that stands for National Committee for something classification. Let me look that up. CLS standards. I'll get it as I'm reading. And what this group does is it will take a organism like Staphylococcus aureus and then take an antibiotic like penicillin G and then make a table. And if the table will have 20 millimeters as the cutoff, and if the zone of inhibition measured in the diameter is less than 20 millimeters or equal to 20 millimeters, we say that this organism, Staphylococcus aureus, is resistant to penicillin G. On the other hand, if the zone of inhibition is 29 or greater millimeters, then we say Staphylococcus aureus is sensitive to penicillin G. And in between, meaning 21 to 28 millimeters, you say that the bacteria, Staphylococcus aureus, is intermediate to penicillin G. And so in this table, we'll have each species of bacteria and each antibiotic, and then there will be probably 3 entries in the table, one for the size of resistance, smaller or equal to, it's resistant, and then greater than 29, it's sensitive to that antibiotic, and then if in between, it's intermediate. And that will have a table having all the species you can think of, and then all the antibiotics you can think of. So it's a very large table. Any question about any of that?
No, that name you were saying, the NCCLS, National Committee for Clinical Laboratory Standards, and it says they've changed the name since 2005.
Oh, really? Is it the same initials?
No, it's not. Now it's CLSI. It's Clinical and Laboratory Standards Institute. And it says in 2005 from 5 different sources. It said in 2005 they changed it.
Ah, well, this must have been May before 2005, and I'm going to guess that probably when we set this up, because we set this up in about 2019 or 2020 when the epidemic came with COVID-19. We grabbed this, and so that's where it came from. And And obviously that was well after 2005. But anyways, the point is there's a table, and I guess I'll point out to my department chair and the head of microbiology that this name has changed. But thank you for that. I didn't know that. All right, so the important part is that they make a table which you gotta look at for each species and which each antibiotic, and then you measure the sizes of the zone of inhibition, the diameter, and then look at the table, and if it's smaller than the size stated for resistant, we say that's resistant, and if it's larger than the size for sensitive, you say it's sensitive, and in between, it's intermediate. Any question about any of that? All right. Where was I here? All right, let me restate that the zone size is dependent on several factors. Obviously, it is dependent on how sensitive the bacteria is to the antibiotic, but it's also dependent on the diffusion rate of the antibiotic. A smaller molecular weight antibiotic will diffuse further and have a larger zone of inhibition. The growth rate of the bacterium will also affect the zone of inhibition. The faster the bacteria grows, the larger the zone of inhibition. And then a few other variables can also affect the size of the zone of inhibition. And because of that, we have a standard protocol for doing the Kirby-Bayer test, meaning you always start the Kirby-Bayer test from inoculating a nutrient broth using several bacteria colonies isolated on non-selective media that are no more than 24 hours old. You grow the broth till the turbidity reaches 0.5 McFarland standard units, and that will be about 1 times 10 to the fifth organism per mil. If you're slightly beyond that, you can dilute it down to 0.5 McFarland units. If it's less than that, you grow it longer. And if it's way beyond that, you should restart the experiment because the cells have been too old. But generally, people grow it until it's about 0.05 McFarland units and then dilute it to get it down to 0.5 McFarland units. You then use that bacteria to inoculate at room temperature a Mueller-Henton agar plate. Other media can affect the size of the zone of inhibition. So we'll always do this in using Mueller-Henton agar plates. And the pH of the plate should be between pH 7.2 and 7.4. Obviously, a different pH can affect the zone of inhibition as well. We always make the Mueller-Henton agar 4 millimeters in depth because you have deeper agar, you'll have a smaller zone of inhibition because the molecule will have a harder time diffusing out of the and through the agar. And we always use a diameter plate of 150 millimeters. I don't think that one will affect the zone of inhibition, but I've never tried it to, see if it does, but I think that's just a standard they do. You always use a sterile, non-toxic swab to apply the bacteria, spreading the bacteria everywhere on the plate so it grows as a lawn of bacteria, getting confluent growth everywhere in the plate. You then place discs at least 24 millimeters apart, a paper disc, no more than 12 discs per plate, and inside the disc will be the antibiotic. Inside in the paper disc will be the antibiotic. You always add the antibiotic disc 5 minutes after you add the bacteria, but no longer than 15 minutes after you add the bacteria to the agar. You then incubate the plates no longer than 15 minutes after adding the antibiotic disc. You put them in a non-CO2 incubator and let them grow for 16 to 18 hours at 35 degrees Celsius. Obviously, at least some species, if you grew them at a higher temperature or you grew them for a longer period of time, you'll have a smaller zone of inhibition because you have more bacteria growing. Any question about any of that? All right, after incubation, you then measure the inhibition zone sizes by measuring the diameter using millimeters. You then look at that measurement, compare it to the table, which used to be called the National Committee for Clinical Laboratory Studies, or NCCLS. And what again was the initials? Does anyone remember? Oh, don't worry about it. It is not in this lab module.
It's NCCLS.
NC.
The one we're using in the lab is
No, I
NCCLS.
got that. I got that. What's the new initial?
Oh, CLSI. I'll email it to you.
I got it.
Okay.
CLSI. Yeah. All right. All right. So if the bacteria are considered sensitive, uh, only if the diameter is larger than the size that the NCCLS table says is sensitive, and if it's smaller than the size that the table says is resistant, then the bacteria is resistant for that antibiotic. And if it's someplace in between, we say it is intermediate for that antibiotic. So each species of bacteria, like Staphylococcus aureus, in each antibiotic will have a different standard in the table. Any question about that? So here we're measuring the size here, and that's very close to about 20 millimeters, which would be that Staphylococcus aureus is sensitive to penicillin. Any question about any of that? Excuse me, not sensitive, resistant to penicillin. All right, there's the terms for this lab. Don't need to look at the references, but you may. You're not going to be physically performing any of these activities because everything we do will be done online, but you will be held responsible for learning how to interpret the effectiveness of antibiotics using the Kirby-Bauer disk diffusion method. You can view a little movie showing you how to prepare a spread plate, getting a plate of agar with bacteria growing on it using the spread plate method, and then review the steps for using aseptic technique for preparing a spread plate or a bacterial lawn of growth. Let me go ahead and show you. We're going to pretend that this is the plate. Let me stop the share here and then I can see it better. And you'll see it better too, I think. And we're going to pretend that this is my loop, or actually a swab. You take the swab and come up to your stock culture, which has liquid broth in it. This is a sterile swab. Put the broth in the liquid, and then you get the worst of the liquid off the swab by touching it to the inside of the tube, touching the sides, just to remove a little bit so that there isn't dripping amount on the swab. And then you take your swab to the disc. I've taken the lid off. And then you swab the disc everywhere on the bottom of the disc so that we have growth growing everywhere. And then you rotate the swab a quarter of a turn, rotate the disc. I'm not going to show you, but there we go. Rotate the disc a quarter of a turn. It's actually a half of a turn, but you got the point. And then you swab once again. I'm going to do it this way so you can see it better. You swab the disc a second time, swabbing everywhere. And then you rotate the swab a quarter of a turn, rotate the disc a quarter of a turn, and once again you swab everywhere. The point is to get sure that the bacteria are going everywhere. And so that's why we're swabbing everywhere. And you need to do it at least 3 times. Occasionally the procedure will say 4 times, but in this lab it says 3 times. And then when you're all done, you take the swab and you go around the edge of the plate. The reason is to get the bacteria to grow everywhere, because when you're swabbing, let me see if I can get that showing. When you're swabbing and going like this, occasionally you might miss a little spot right on the edge. And that's why we take the swab and go around the edge. I once had a student who went doop, 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 doop. I don't know if you can see that, but not everywhere. Just like, I think she did 3 swabs. And then she did this one, doing once again 3 swabs. And then going like this, going 3 swabs. And then she came up to me with the plate and said, how can I measure the diameter of the zone of inhibition when I have bacteria not everywhere in the plate and it's only in certain streaks? And I looked at it and said, well, you didn't swab everywhere, so it's very difficult to measure the zone of inhibition. In fact, it was impossible. Uh, and I told her to either redo it, repeat the experiment, doing it again, or to use her lab partner's results because she couldn't measure her zone of inhibition. So you need to make the bacteria growing everywhere on the plate. Obviously, that was when I was teaching in the lab. All right, let me share my screen again. Don't put the cotton swab down on the lab bench when you're all done. It should be put in the place for putting swabs, meaning a little uh, beaker of a disinfectant. All right. Then you allow the uh, bacteria to sit for at least 5 minutes, less than 15 minutes, to absorb the liquid. And after 5 minutes, you can then put the paper disc down containing the antibiotic. And then 15 minutes, no longer than 15 minutes, between 0 minutes to 15 minutes after you put the paper disc down. You then flip the uh, tube, the plate upside down, and then grow it upside down in the incubator for 16 to 18 hours at 35 degrees. And that's how you do the Kirby Bayer method. Any question about any of that? All right, then view the following video clips. Preparing a culture for Kirby Bayer disk diffusion, interpretation of the results for Kirby Bayer disk diffusion, and then the virtual lab. Let's click on that and open it. If you have a slow internet connection, this may take time to download. I've got a fairly quick internet connection. For this virtual lab, click the button Start, and you can read how to do it in the menu, but essentially what you're going to do is measure the sizes of the zone of inhibition. What you do is you grab the ruler and bring it up. We're going to take it to this one, put it in the diameter about there, about there. And I'm going to say that's about 17 millimeters for TE, which means it's intermediate. If you get the correct answer, it'll be green. Let's go there. Erythromycin. We're going to say 14 to 17. Incorrect answer, it'll give an X, a red X. Another incorrect answer, a red X. The correct answer there, it's less than 13, which means it's resistant. This is intermediate. This is sensitive. And where's one that's sensitive? This one that's about 30 millimeters, maybe 29. That's C. So that's definitely sensitive. All right. Uh, and then to get to the next plate, this is a plate for E. coli being tested with these different antibiotics. Hit the menu button and then restart. It goes to the second page for Pseudomonas aeruginosa. And then hit the menu button again, hit restart third time. And there's the third plate for Staphylococcus aureus. And there's the only antibiotic which has a zone of inhibition. So I'm going to guess this is actually MRSA because all of these different antibiotics, the Staphylococcus aureus has become resistant to. The only one it's not is vancomycin. And if you don't know, vancomycin is the backup antibiotic to use for Staphylococcus aureus that has become resistant to most antibiotics, or meaning MRSA or MRSA. Any question about any of that? All right, you do need to do the virtual lab to answer some of the questions in the lab worksheet. And you hit restart again the fourth time, comes back to the first plate. Any question on any of that? If not, let's go out of there, back to the lab. Using the standards required for the Kirby biosusceptibility testing, an E. coli culture is prepared using a spread plate technique. Antibiotic discs are placed on the surface of the agar. The agar is incubated overnight at 35 degrees. Below are the results for the NCCLS zone standards used for interpretation. And then the diameter of the zone of inhibition using calipers. Let's go right there. There's the caliper, the zone of inhibition. And then the table for the NCCLS, the measurement for resistance, the measurement for sensitive, and then the measurement for intermediate. We're not going to use Staphylococcus aureus, but we are using E. coli. All right, can somebody tell me the size of the zone of inhibition for ampicillin?
15 millimeters.
Yes, you've used calipers before, or you read ahead that on a caliper you measure it from the 0 to the 0, which would be 15 millimeters. Or maybe I think I've got the answer there. I shouldn't have asked that one, should I? Yep, I've got the answer right there. All right. You do not read the caliper from here to there, so that would be like 10. You read it from 0 to 0. And the reason why you don't measure from here to there is because this 0 is not placed here. You place there and you read it from there to there. Okay, any question about using the calipers? All right. So the first one I've given to you, you can Then take a look at where 15 millimeters is for ampicillin, and the bacteria is E. coli. 15 millimeters. I'm not sure I'm going to get this. Let me shrink down the table. 15 millimeters is intermediate for ampicillin. So the correct answer is an I there. And then fill in this table for the size of the zone of inhibition. Measure it, the diameter in millimeters, put it here. And then tell me the interpretation. S for sensitive, I for intermediate, R for resistant. Fill in the table there. And to get that, you take your measurement and then take a look at the table for E. coli right here. Any question about any of that? All right, that's the first question. I think this one is worth 4 points. 1, 2, 3, 4, although I've given you the first one. Not 4 points, 0.4 points. Sorry, 0.4 points. And then answer question 3. List the variables that must be standardized when performing the antibiotic susceptibility test, meaning the Kirby-Bayer method, using, never mind, the Kirby-Bayer diffusion method. And this is given to you in the lab module. Okay? So state it there. And once again, you have to fill in an answer for each asterisk. So 3, 4, 5 things that we standardize in the Kirby-Bayer diffusion test. And then answer question 1. The size of the zone of inhibition often varies for 2 different species of bacteria when challenged with the same antibiotic. What is a possible explanation for these differences? Give your answer there. 2. What would happen if we didn't use aseptic technique to put the antibiotic disc on the plate? So give me your answer here, and then answer what happens in the results of the test. So if you didn't answer that before, answer it now. So what would happen to the plate, and then what would happen to the results of that plate? And then 3, what would happen if we increased the concentration of the antibiotic in the disc, and what would happen if we decrease the concentration of the antibiotic in the disc? Be specific and tell me what's going to happen to both when you increase and decrease the concentration of antibiotic in the disc. 5, antibiotics can be bactericidal, that is, they kill microbes, or bacteriostatic, they inhibit microbial growth but do not kill the cells. When observing a zone of inhibition around a disc, how would you determine whether the antibiotic causing that zone was bactericidal or was bacteriostatic? I will warn you, this question is a thinking question, and oftentimes students get it wrong on the first lab, but most students do get it correct on the second lab, meaning a second turn in. Any question about any of that? All right. So like I said, that's a thinking question. Work on it. And 5, when performing antibiotic sensitivity testing, it's important that the test conditions are kept very standardized. The same kind of media, Mueller-Hinton, the same agar depth, 4 millimeters. The age of the culture, a young culture like growing less than a day or a day, no longer than a day. And then why is that? Explain your answer. 6, are there other substances besides antibiotics that we could evaluate using this method? By this method, they mean the Kirby-Bayer diffusion method. And you should name at least one substance that we can use the Kirby-Bayer method on to evaluate it. And it cannot be an antibiotic. So don't tell me something like penicillin G or penicillin V. 7. Does the presence of a zone of inhibition necessarily mean the bacterium being tested is susceptible to the antibiotic? Oh, I see. Never mind. Let's go to the worksheet. I've changed the question. That's what is different. I'm reading the wrong thing. I should have went to the worksheet. Now, there's a few extra questions in here. I don't remember which ones I didn't ask. That's just a numbering difference there. All right, 11. From the size of the zone of inhibition of chloramphenicol used on E. coli in the virtual lab, is the bacteria sensitive, intermediate, or resistant to the antibiotic? For chloramphenicol used on Pseudomonas aeruginosa, is the bacteria sensitive, intermediate, or resistant to the antibiotic? And that's question 11, which you will have this one. Like I said, I've updated this page, and mainly the change is obviously I added that question, and I also changed the numbering here. That's question 2. This is question 3, and the next one's 4. I was reading it before. It has 3 and 4, or 2 and 3 twice. Yep, see, 1, 2, 3. All right. All right. Any questions about this lab? If not, I will be here until 8 o'clock to help you with the lab, answer any questions, or until the last student logs out. Any questions? All right, I'm going to stop the recording, but I'm not dropping out of the lab.